So it's really a great pleasure to introduce the next speaker, who really doesn't need any introduction because he's been behind this whole effort all day, Reg Bell. I think we should give him a little hand of applause here. And he has the great task of presenting Individualizing Interventional Therapies, fundo, TIF, RFA, and more. Reg, thanks.
Thanks, Peter. And thank all of you for coming and being part of this movement. It's been incredible, an incredible journey for us, and the enthusiasm that we've seen and the turnout that we've seen just indicates that we've hopefully hit a nerve that is resonating with many people. So I'm going to talk to you about individualizing GERD therapies. And I think we've heard already, just in terms of the landscape, that GERD is not just one disease. We also have this proliferation of new treatments for GERD. Now, one of the issues is that most studies that have been done on these new treatments, in part because they're searching for that mythical beast called reimbursement, they really haven't looked at isolating the most appropriate patients for a given procedure. And therefore, personalized treatment recommendations are really based more on expert opinion, personal experience, or sometimes they're simply just not personalized. Now, one of the great things about this journey for me, having been in private practice and having been involved in this Foregut Society thing, has been the ability to talk to Blair, to Dan Lister, to Tripp, to Peter, others, just along the way saying, hey, what do you think about this? What should I do in this situation? Something that I really haven't had over the years. And that to me has probably been the most rewarding part of all this. But it also means that given that I have the joy of simply saying I don't have to present any data in my talk here because it's just expert opinion, it's also the expert opinion not just of myself but of others that I've chatted with over the years. So you've heard GERD is not one disease, and there are different parts to it in terms of reflux burden, the reflux mechanism, how the esophagus gets reflux back up into it and then clears it, anatomy such as hiatal hernias, tissue permeability issues, and then the more obscure things from a surgeon's point of view of visceral sensitivity and cognitive response. But all of these things go into affecting quality of life. And I'm going to focus on the ones that I can talk about reasonably well as a surgeon, which have to do with anatomy, reflux mechanism, things like that. But I want to emphasize that the tissue permeability, visceral sensitivity, cognitive response are all things that are very, very important, and I think go to that understanding that this is a complex mechanism that we're dealing with. So we've heard that there is one gold standard for treating GERD. It's lapnicin. And there are two parts to this. One is, if GERD is not one disease, how can you have a gold standard? And secondly, as Peter Carilla said yesterday, really the nisin just kind of got grandfathered in as a gold standard because there wasn't anything else around. So we're going to challenge that notion. And we have all these good other modalities, and so it actually is good. If GERD is not one disease, it's great that we have these different modalities to deal with. So when I see a patient in the office, there are a bunch of different scattered things going through my brain. And so they come down to the type of symptom, the mechanism of reflux, esophageal sensitivity, esophageal clearance, response of the patient to acid suppressive medication, severity of injury, and then patient expectations. So we've already heard that in terms of types of symptoms, if I see a patient who has regurgitation, I am thrilled. I'm absolutely thrilled because I know I can make that patient better. And I think it's taken me a while to start to listen to patients to elicit that symptom because so often it's ignored in our standard, do you have heartburn? Yeah, I got heartburn. Do you have regurgitation? Well, sure I got regurgitation. I got reflux. It takes a little while to cull that symptom out at times. But when I find that symptom, I know that I'm going to do extremely well. And you've seen this study before that I was fortunate enough to be the lead author on, but it was really multiple sites that made all this possible, showing that regurgitative symptoms respond phenomenally well to an anti-reflux procedure, in this case magnetic sphincter augmentation, and do phenomenally poorly with increased doses of acid suppressive medication. And it makes it a very easy decision to tell someone, you're going to do great with this. Let's not mess with medications. So how about mechanism of reflux? Well, you've all heard over the past few hours about transient LES relaxations and also loss of the primary sphincter. But I think more and more, following John Lipham's line earlier today, we're realizing that sphincter separation is a significant component to reflux. And probably one of the most interesting studies I've come across recently is one by Sumit Mittal, when he talked about swallow-related transient hiatal hernias. And what he noticed is in patients presenting to his clinic being evaluated for reflux surgery, there were some patients in whom he would have a swallow and the crural diaphragm and the lower esophageal sphincter did not separate. And there were others in whom there was a subtle separation just for a few seconds after a swallow between the lower esophageal sphincter and the crural diaphragm. And interestingly, 60% of patients who had this transient swallow-related hiatal hernia, they had no other obvious evidence of a hiatal hernia, just this transient separation during a swallow. 60% of them had reflux versus only about 25% who did not have that. So it raises a question about how subtly we need to be in picking up hiatal hernias or that crural component to the anti-reflux barrier when we think about endoscopic procedures. Esophageal sensitivity I'll come back to in a little bit, but how about, I guess I'd say, the basic anatomy and esophageal clearance? Well, I think we all know that reflux patterns kind of fall into three distinct types. There's the upright refluxor, there's the supine refluxor, there's the bipositional refluxor. And the upright refluxor, good data to show that they are more prone to gas bloat if they have a fundoplication. They tend to have reflux more on the basis of transient LES relaxations, and these are often the patients that Ken Chang alluded to may do very well with a, they may have early disease and they may do well with an endoscopic procedure. Patients who have supine reflux alone tend to be a lower risk for gas bloat. And then there are the bipositional refluxors. And I think one of the most important things is that across the board, bipositional refluxors are the most likely to have defects both in the LES and in the crural diaphragm and to have a hiatal hernia. And if I see a bipositional refluxor, if I don't see a hernia, I start looking for one because there's a pretty good chance I'm overlooking one because so many of them have a crural defect and a hiatal hernia. And the other part is these are the patients that I think, going back to Brent Oschlager, these are the patients that may need that supraphysiologic valve of a complete fundoplication. How about esophageal motility? Well, suffice it to say, IEM, first off, it's a very poorly defined concept. Really, it started out with Don Castell showing not anything to do with dysphagia. It had to do showing with patients who had reflux were more likely to have impaired motility. No prediction of dysphagia was ever in that initial discussion. And then we transferred it over to high-res manometry with some vague numbers that really haven't been validated in a lot of ways. But mostly what I don't like about it is that IEM is just not one entity. These are a couple of slides from Dan Lister. Both of these patients have IEM. This one has a large peristaltic gap in the distal esophagus. This one has a peristaltic gap in the proximal esophagus, but the distal esophagus is really looking pretty good. And when I think about doing an anti-reflux procedure and recognizing that I'm going to increase a barrier to outflow in the distal esophagus, especially if I'm thinking about a magnetic sphincter augmentation, I want to know if there's good distal contractile oomph. And I'm proposing that as a new term for the Chicago classification, the DCO. I don't know that it'll get anywhere, but I'll propose it. How about EGJ outflow? Well, this again is a term I really have problems with when it comes to using the term EGJ outflow obstruction. One of the problems is that Chicago classification is a classification schema, not a diagnostic schema, but the term obstruction implies a diagnosis. And I really prefer to use the term elevated IRP. If I see an elevated IRP, I think it ought to be called an elevated IRP, unless I see clear evidence of obstruction, like an elevated intrabolus pressure, or what we call sometimes a stiletto heel slipper, where there's a clear bolus pressure increase at the start of relaxation. More than anything, though, I think even if there is genuine EGJ outflow obstruction, it turns out it's often related to an anatomic abnormality, and that anatomic abnormality actually is frequently a hiatal hernia. And this is a study by Paul Menard-Ketcher and his colleagues at UC Health, showing that about 2/3 of patients who had elevated IRP had anatomic abnormalities as a potential source. Hiatal hernia was the most common. Previous anti-reflux operation was the second. Strictures and narrowing was the third. And you can imagine that if a patient has a big hiatal hernia, they can have EGJ outflow obstruction just on the basis of the hernia. And the important part in all this is that if they have EGJ outflow obstruction on the basis of a hiatal hernia, don't do a myotomy on them, please. But secondly, they will do very well if their hiatal hernia is fixed, and they won't have dysphagia afterwards if they have a fundoplication. Another aspect to this whole hiatal hernia deal is pressurization in the hernia sac itself. And these are some slides from Christy Dunst. Thank you, Christy. Showing on the left a patient who has a hiatal hernia. There's separation of the crural diaphragm from the lower esophageal sphincter. And in that hernia component, there's actually inspiratory reduction in pressure. It's kind of what you'd think of as a normal expectation. Patient on the screen right has pressurization in the hernia sac itself. And there's good data to show that especially if this occurs in the supine position, these patients will reflux from the hernia sac. So when you do manometry, and I don't know that Flip is quite ready to bypass this kind of information. When you do manometry, pay careful attention to some of these little factors like swallow-related transient hiatal hernias or pressurization in the hernia sac, because it's going to give you some more information about what's going on and what's going on anatomically, functionally in this patient. How about response to acid suppressive medication? Well, there are some patients who have a complete response to acid suppressive medication. They come in saying, I want to be off PPIs, whatever. And I agree completely with Brant Oschlager. First off, I don't diss PPIs. I think, let's put it this way, they're a very safe drug. They're probably safer than most surgeons. Okay. And I think I'm a pretty damn good surgeon, but I got to admit they're safer than I am. But there are patients that want to be off of it. And so that patient ought to have a procedure that has minimal risk, minimal side effects, because they're doing great on PPIs. And so I will not offer that patient a Nissen. I'm sorry, they won't get a Nissen from me. That's overkill, pardon the term, for what they need. The partial responder, I think one of the things that we've ignored, and it's been ignored in the studies that we've done, is that if we take a patient who's uncontrolled on PPIs to controlled on PPIs, that's a therapeutic victory. But every study we've done has looked at resumption of PPIs as a failure marker, right? And that doesn't do us any service when it comes to looking for reimbursement, that mythical beast. So we need to start looking at studies that look at a clinically valid endpoint, which is improvement of quality of life, even if it involves both medication and an intervention. And typically in those patients, they will be willing to accept a lower potential success rate if the procedure is less invasive, and if I haven't made the mistake at the beginning of dissing PPIs and telling them that they're bad shit. And then the patient who has no response to PPIs, well, there's an old adage that patients should show some response to PPIs to be a candidate for anti-reflux procedures. Earlier on, you saw a slide from one of Marcelo Vella's studies showing that, interestingly, heartburn could occur with non-acid reflux. So it raises that question about heartburn. More to the point, I think, clearly regurgitative symptoms. Regurgitative symptoms don't frequently respond to PPIs, and that in no way predicts the success of a surgical treatment. And actually, when we started to look at that group of patients who had ongoing regurgitation in this Caliber study, those patients who did not respond at all to regurgitation, the regurgitative symptoms not respond at all to PPIs, those patients did as well as patients who showed some response in their regurgitative symptoms to PPIs. And it was the same actually for heartburn. So in that group of patients, heartburn will improve with surgery even though it doesn't change one iota with the PPI. Severity of injury, I think, just very briefly, these are the patients who have life-threatening disease. They ought to get a Nissen. And then patient expectation is something we all take into account in terms of quality of life. How much does this impact their quality of life? And so forth. So we have all these different considerations that are going through my mind, and I have all these kind of options, and I'm trying to put them all together. And of course, surgeons are monkeys, so it's apes. So it takes us a little time to process all this, and I don't know that I have it all processed, but I'll go through some thoughts, because it really is all a balancing act. So how do we make order of this disorder? Well, first off, I think my first thought is, does the patient need a laparoscopic procedure? Because that changes my whole thought process in terms of which direction we're going. And so if they have crural separation, if they have a crural defect, then I need to put that crural sphincter back in opposition to the lower esophageal sphincter if I'm going to do a good job restoring things. So what are the options if you're going to restore the crural diaphragm? Well, you can do a Nissen. It does, in addition to restoring the crural diaphragm, restore LES pressure, restores LES length, but it is a supraphysiologic flap valve, and I think there is no doubt about that, and that's why patients get gas blowed. And in fact, Bill Richardson, some years ago, took a pig's stomach, and he did a Nissen, and he also did a Toupet. He started distending the pig's stomach to see at what pressure this valve would give way. Lo and behold, the sutures tore out of the wrap before the valve would give way. It's a supraphysiologic flap valve. And that's a problem with it. It's good when you need that to control reflux, to prevent aspiration, but it's not something we need 90% of the time, and I rarely do it anymore. I've gone to doing partial fundoplications, and I actually follow Dave Watson's approach of doing an anterior fundoplication because I don't have to divide the short gastrics, and I can kind of tailor how much I wrap it around, but that's a personal preference. It's still a flap valve, but I have found that there is, first off, less outflow resistance than with a Nissen, so I can do it in patients who are aperistaltic. And also, there is less severe gas bloat. It's still present, but it's less severe, at least in our practice. And so when I have to do a fundo, that's my preference. Now, how about magnetic sphincter augmentation? I think, for me, the way that I understand it the best and the way I explain it to patients best is that it's a pressure release valve. And so in this video, there's a pig's stomach there, and the numbers on the right of the screen are the pressures, and gradually this stomach is being insufflated with water, and at about 11 millimeters, it starts to leak, okay? Now, let's take that and put a lynx around it, and let's start increasing the pressure, 23, 24, 25, 26, 27, at about 28 millimeters of mercury pressure, those beads pop apart. Now, in a lynx, it wouldn't really fly apart like that, okay? Just so we're clear, this was intentionally not gathered together to show the pressure at which one set of magnets would separate. So I think of it as a pressure release valve. And if you wonder where we got that number of, in our studies of a distal esophageal amplitude of 35 or more as a criteria for doing a lynx, well, 28 millimeters is about the pressure at which it opens up. So I want to make sure that there's enough peristaltic oomph in that distal esophagus to open this thing up. But that also helps me understand and helps me explain to patients why they can burp and vomit after this. LES stimulation, Vic gave a nice overview of that, and we know that there's still some data pending. But I will say in our experience, because we've been doing this for a few years as part of the less GERD study, that gas bloat and dysphagia are really minimal after this. And so it may have a big role in patients who have significant dysmotility. So how about the endoscopic procedures? Well, they don't restore the crural sphincter. And so historically, we've used this 2-centimeter axial component to the hernia as a limiting factor. I think it's really more the transverse dimension, which has to do with crural competence. And so when I'm evaluating someone endoscopically to see if they're a potential candidate for an endoscopic procedure, I retroflex the scope, and I will actually provocatively sometimes pull the scope back into the hiatus to try to open it up to see what the transverse dimension is. And if it's more than about 2 centimeters or 2 widths of the scope, then I get suspicious about my ability to get a good result with a purely endoscopic procedure. So think about that transverse dimension, not necessarily the height of the hernia alone, but the two in combination. So with that, RF bulking, I think the one place that we really haven't thought about it much is maybe as an alternative to neuromodulators in the acid-sensitive esophagus. And this was a study by Daniel Sifram and his colleagues showing that after RF bulking of the lower esophageal sphincter, that patients actually had less acid sensitivity in the distal esophagus. So just a thought, one study needs to be thought about a little bit more. TIF, I've done about 160, and frankly, we stopped doing them partly because of this phenomenon of base rate neglect. I lost track of the patients that were doing well. I just remember the patients that I was seeing back that were doing poorly and reoperated on. So after about 5 years, I went back and I thought, you know, maybe we ought to go back and look at all of our patients. And I'll be honest and say I was really amazed. We now have patients out 9 years, one patient out 9 years. And the patients that have done well and have done very well long term. So I think there is some increasing data, ours is not alone, saying that this looks like it may be a very durable procedure. There may be some early failures and we need to sort out how to avoid those early failures, but it looks like it's a pretty durable long-term procedure. And then recently we've been investigating, as part of an FDA study, something that Bob Gans looked at a few years ago, and that is pyrolytic carbon particle bulking of the lower esophageal sphincter. These are the same microcarbon particles that are used for urethral bulking for urinary incontinence. And it may be something that will help out, again, in that very early disease. The nice thing is that it's fully reversible. If you get too much bulking in, you just open up the mucosa, because it's a submucosal injection. Just open up the mucosa and this gel falls out. So not very invasive. So just to kind of start to summarize, there's some specific key concepts that I'd like to just sort of highlight again. One is that the flap valve of a fundoplication is very effective, but it is supraphysiologic. Secondly, that it's not just a hernia that needs reducing. It's the secondary crural sphincter that needs restoration. So it's not just the hernia, it's the crura. And we need to figure out better ways to diagnose this defect preoperatively. We also need to think about how we calibrate the restoration of that, because it's not just fixing a hernia, it's restoring a secondary sphincter. We haven't really thought about that. And thirdly, my plea for a new Chicago classification. And lastly, that not all elevated IRP is EGJ outflow obstruction, but when it is genuine, think that it's an anatomic abnormality and that might be a hiatal hernia. And then more globally, just going back, GERD is not one disease, and so precision care requires knowledge, requires the ability to execute different treatment modalities. We can't just be doing one thing anymore if we want to be an expert in this field. And we need to move from stacking one therapy against another, whether it be against a Nissen or whatever, to saying how can we best use this therapy in this patient phenotype. We need to recognize that it's okay to take a patient uncontrolled on medication to controlled on medication and see that as a therapeutic victory, not a failure of surgery. There can't be a gold standard if GERD is not one disease. And because of that, we need these multiple therapeutic options. So again, it's a balancing act and it requires specialized knowledge and skill. I think, to carry this all off, and I think that's why we're all here, because we want to increase that specialized knowledge and skill. So thank you very much.